If a mass is neither round nor oval, it should be described as irregular. This feature is highly suspicious for many cancers. In this case, a small mass is seen in two views. It can neither be described as oval or round, and therefore should be described as irregular. This proved to be a small invasive cancer. Next to be described is the orientation of the mass with respect to the skin. The options here are a mass which is parallel to the skin and one which is not parallel. Lesions that are not parallel to the skin may also be described as taller than wide, and this includes lesions which are round or spherical. Here examples of parallel and not parallel lesions are shown. An intramammary lymph node on the left, which is parallel to the skin, and a small cancer, which is not parallel, in the right. Here another example of an invasive cancer in which the long axis is perpendicular rather than parallel to the skin. The next feature to be described is the margin of the mass. This is the edge or border of the lesion. A number of descriptions may be used to describe mass margins, and these are generally ranked in the order of increasing correlation with malignancy. Often lesions will have several margin characteristics, in which case the descriptor with the highest suspicion for malignancy should be selected. Margins may be circumscribed or not circumscribed, in which case they may be described by a variety of terms, including indistinct, angular, microlobulated, or spiculated. Circumscribed margins are well-defined, sharp, with an abrupt transition between the lesion and the surrounding tissues, as is shown in this example of a simple cyst. Most of these lesions with circumscribed margins also have round or oval shapes. Here's a fibroadenoma which shows a circumscribed margin, sharply defining the mass from the surrounding breast tissue on the left, and a smaller lesion, also fibroadenoma, showing similar features on the right. If the mass is not circumscribed, it may consist of one or more of the descriptors, including indistinct, angular, microlobulated, or spiculated. In this example, an irregular hypoechoic mass, which is not parallel, is seen. However, the delineation of the mass from the surrounding normal breast tissue is extremely difficult to define and is indistinct. Here are additional examples of lesions with indistinct margins. Each of these represents an invasive cancer. In this example, the margin is indistinct, but also shows clear-cut areas of angulation and spiculation, which would be additional terms applied to the indistinct descriptor. And here another cancer also showing extensive irregularity with spiculation around the margins, this finding often indicating the presence of invasion of the cancer into the surrounding soft tissue. In addition to the margin, often a lesion boundary is visible. This is the transition zone between the mass and the surrounding tissue. This boundary may result in an abrupt interface between the lesion and the surrounding tissue, or may consist of an echogenic halo, in which there is no sharp demarcation between the mass and the surrounding tissue, but with an echogenic zone of transition. This is often associated with carcinoma and also may be seen with abscesses. Here we see the comparison of a lesion with a sharp lesion boundary, well defined on the left, and an echogenic halo surrounding the cancer on the right. Again, a cyst with an abrupt boundary and two cancers showing echogenic halos surrounding irregular hypoechoic masses, each of which contains spiculations and microlobulations. Another characteristic described is the echo pattern of the lesion. This may be anechoic, without any internal echoes, as is typical with a simple cyst, hyperechoic relative to the fat and equal to the fibroglandular tissue, complex containing both anechoic and echogenic components, hypoechoic relative to the fat with low-level internal echoes, or isoechoic, showing the same echogenicity as fat. Several of these patterns are shown in this panel, the image on the left being anechoic and representing a small cyst, the one in the center being hyperechoic, consisting of the echogenic hilum of an intramammary lymph node, and the mass on the right being hypoechoic and representing a small ductal carcinoma. With proper gain settings, the cyst should be completely anechoic, and when these features are present, ultrasound is extremely accurate in the definitive diagnosis of cysts. Here a lesion with increased echogenicity compared to fat is shown, resulting in a classification as hyperechoic. And in this example, both cystic and solid elements are present, resulting in a complex description of the echo quality. Occasionally, lesions are very similar in their echogenicity to the surrounding fat. In this case, the lesion is isoechoic. And here an example of a hypoechoic lesion with low-level internal echoes. Again, it is extremely important to be sure that proper gain settings and focal zone placement are used to be certain that low-level echoes are displayed in solid lesions and that low-level echoes representing artifact are not displayed in cystic lesions. Posterior acoustic features represent the attenuation characteristics of the mass with respect to acoustic transmission. Lesions may show no posterior acoustic features, or they may show enhancement with increased posterior echoes or shadowing with decreased posterior echoes, or they may show a combination of both shadowing and enhancement. On the left, a small lesion is seen without any acoustic features. In the middle, typical enhancement with a cyst, and on the right, shadowing associated with a catheter. Here are additional examples of lesions with no posterior acoustic features, the one on the left being a small fibroadenoma, the one on the right being a small cyst. In the case of the cyst shown on the right, compound imaging was used to produce this image. Spatial compounding may result in a diminution of the conspicuity of both enhancement and shadowing and accounts for the relative lack of enhancement in this image.